Dr.NARANG, a very dynamic, versatile surgeon from Narang Eye Care, Ahmedabad, Gujarat. She has a zest to take on very challenging cases, and she's going to teach us some more. So on to you. We might have to shorten our discussions because we still have a huge bunch of speakers to present lovely cases.
Well, my screen is visible.
Yes.
Thank you, Dr. Chitra, for this wonderful opportunity, and the entire ARC team and the AIOS, Dr. Namrata, Dr. Partha, everybody. Thank you so much. So, well, on the best of Dr. Chitra, she said you need to show some pearls and something. So I decided to pull on one of the videos which I have just pulled out. There have been, I'll keep on pausing this video as it's a very short video. Previously, there were two presentations on the posterior polar cataract, and each of them have beautifully shown what to do. Now I show you what not to do, because like what you see in this video is like very drastic, and these are the things that we usually read in books that this is not to be done. So we proceed ahead with this posterior typical polar kind of cataract, and a capsular rhexis has been formed in this case. Everything seems well as of now, but there are certain learning points and certain mistakes which are done. Now the first step here is the hydrodissection. Actually, it was done, and this hydrodissection is not to be done. So this is the first teaching point for a posterior polar cataract. We need to go ahead with the hydrodelineation. That is what we have always learned. Go ahead with hydrodelineation, have a good nucleus, and then you go ahead, and you have to be very soft and smooth while you are handling a polar, because you do not know how the posterior capsule is going to be. So that's the first thing which is not to be done. And then the second thing which is not to be done is the nucleus rotation. Now, when you do this, if you have a small opening out there, you are already creating a very big opening. And these are the two steps which are absolutely barred from doing for a polar cataract. Okay, we go ahead and we proceed with the surgery. This is the phacoemulsification which is ensuing, and we already know that there is some trouble which is waiting for us. So as soon as this phacoemulsification procedure is going on, signs have already started trickling in that, you know, you are seeing some kind of open space out here. So this is the first indication that everything is not good. And then when you see a strand, and you know you are in soup at this time. So, but anyway, this is what we all deserve, because if this is the kind of the surgery that we proceed with, this is the only repercussion which is going to happen in this kind of cataract. So now this is a stage where you need to pause and think how you need to go ahead, because you have a very big open posterior capsule with non-emulsified nuclear material. Okay, now when you have created so many mistakes, you need to rectify it also. And because in the end, you need to have an optimal outcome. Your outcomes have to be optimal, not suboptimal. So now what is planned for this kind of case is actually, you know, the vitrectomy procedure that has to be done. And now what you are actually, I'm just pausing these videos because now a pars plana trocars have been placed into position. Fluid infusion is going from behind. We need to do a pars plana vitrectomy in this case, because you need to cut down the vitreous strands from behind, and you need to free up this nucleus material from the vitreous, which is propping up from behind. So what we're seeing here is that, you know, the vitrectomy is already going on, but the nucleus is also being, you know, an effort is being made to keep this nucleus up into the anterior chamber, and you keep on cutting all the fragments, all the nuclear material and your vitreous from behind. So this is the non-emulsified nuclear material which has been brought effectively into the anterior chamber. Thankfully, everything is going on well right now. So now we all know the wonderful procedure of an AIOS scaffold in these kind of situations. So trying to further rectify the procedure, you know, this tunnel is created, a leverage has been created, and a 3-piece foldable intraocular lens is now taken, and this is being injected. So now the optic of the intraocular lens, now of this 3-piece intraocular lens, it acts as a scaffold. So now when you have a scaffold like this, you know, you can emulsify this nuclear fragment with your phacoemulsification probe. I just pause this video here. Actually, when you are doing an AIOS scaffold, you have an option, you know, you can either, you know, you have a very good rhexis in this case, thankfully. So you can place the haptics on the rhexis. You can place the haptics on the rhexis, and In case if there is a bigger nuclear fragment and there is non-visualization of the rexus margin, or sometimes the pupil also comes down. Actually, many times it's beneficial at this stage if your pupil closes down a bit, because it prevents the flipping back of the fragment from either side into the posterior cavity. But anyway, you can also place the haptics onto the anterior surface of the iris, or you can place it on the sulcus. So these are the two positions that you can have when you're doing this. The idea is to just block the pupillary area and not let this fragment go behind. So you go ahead with this, phacoemulsification is being done, and you can see now there's no vitreous strand coming up, and the nuclear material is now being chopped off. And this beautifully goes on because there's no vitreous popping up now into the anterior chamber. So having done that, you just close this. One more teaching point that I want to give is that, whenever you have a rent and you're closing down the surgery, you do not, you take one suture at least, because there's no harm in taking the suture when you have a vitreous out there, no matter how good amount of vitrectomy you have done. But it's always better to take a corneal suture and seal the wound. And you can, in this case, we also need to place up the intraocular lens. So now, one more teaching point: if you're not visualizing the anterior margin of the capsule, you need to use iris hooks, retract the iris, visualize the margin of the rexus, and then dial the intraocular lens. Now you again have an option. You can go ahead with the optic capture that has been taught to all of us, because it helps to stabilize the intraocular lens, prevents its rotation in the postoperative period, and it gives a lot of stability to the intraocular lens fixation, and everything settles down very beautifully. So once you are happy with what you have done right now, happy in the sense not for what you created initially, but for what you did later on, you rectified everything, you can just go ahead, release the iris hooks, and you're almost sorted for this. And the only thing is that, you need to have a good posterior segment visualization. You need to check it up before you close down everything, because you need not have any nuclear fragments going down behind. So because otherwise, then you also need to clean up the posterior segment. So anyway, this case ended up beautifully, but I just wanted to show that actually what is not to be done when you have a polar cataract, because you might end up having all these complications, and you need to be well versed if you have all these complications, how to handle them and how to go ahead with it. Thank you so much.
Thanks a lot, Dr. Priya, for showing us a very challenging case. Namrata, I would want to ask you here, the way Namrata, are you there?
Yeah, I'm there.
Yeah,
I'm there.
the way she's done it, would you feel that this case should have been given to a posterior segment surgeon to remove it to the fragmentome? Because levitation, however much and vitrectomy you think you have done, there could be some traction at the vitreous base. So you think getting the nucleus up, does it make sense at all with the way kind of retina surgeons we have with us?
I think Chitra, if Priya is doing it, then she can just go
No, I think the idea is for the learning for the attendees
for
here.
learning, maybe if you're not confident to, or if you don't know how to actually put in an IOL and make a scaffold out of it, and then put the lens, get the fragment to come on the top, it is, left to the posterior segment surgeon if you're not confident of, handling it. Having said this, Chitra, I've seen 2 posterior polar, and this is the 3rd one. And I just cannot help saying, I know that not everybody would be having a high definition ASOCT or an intra-op OCT microscope, but I just cannot help saying that those kind of tools or pre-operative evaluation of posterior polar cataract, especially on a high definition ASOCT or intra-op OCT, or even if you're doing flex on a OCT, which is live, just helps you to know, whether you're going to have a rent or not. The first 2 cases shown earlier did not have a rent, and this one, did have a rent. And of course, flax, I think, would be the way to go. Of course, if you don't have it, that's a different thing. But I always feel that for posterior polar, flex is the way to go now, because it's a lot more control. You can make those 3 cylinders, and you can make those 3 spikes or chops, and then block by block, you can just eat away those blocks, and then get away with the case. But I think Priya very nicely managed, and lot of teaching pearls, I think, in a single case which you showed.
Yeah, I want to add just one more point. There is one teaching point for all those people who are not into vitrectomies. If you have any complication like this coming up, the best thing is to take 2 corneal sutures and send it to a referral center or to any of your vitreoretinal friend or anybody who is handling it. Secondly, if you have a nuclear fragment which has slipped down into the mid-vitreous, do not go and fish it and bring it up. What you saw in the video was the lenticular fragment was still in the anterior chamber, and I did a pars plana vitrectomy and tried to manage it up there, and I was cutting down all the vitreous. It was not that it has gone down and I have tried to bring it up. So that's the second teaching point. Third teaching point, everybody should know how to do a vitrectomy. That's a very initial tool, and I think we need to go ahead. All the cataract surgeons, they should be taught at least minimal vitrectomy where they can handle just their own complication. I don't say everybody should be knowing how to do a vitrectomy in the posterior segment, but yes, for the anterior segment, we should know how to do it. Even when you're referring a patient to somebody else, if you do a good amount of vitrectomy, take a suture and you send it, your patient will be coming up with a better vision in the post-operative period, because you have cut down the traction at that point of time, and maybe that patient might be getting operated by someone else after maybe 24 hours or 48 hours or 72 hours. So during that time, the eye is going to be quite silent. So
I just want to ask one case. Was this case done under topical, or did you block it in between? Was it blocked earlier? Huh?
It's a block. It's a rule that if it's a posterior polar cataract, it is always better to give a block, because we don't want to do many more heroic things, doing under topical and then coming up with a complication. So it's always better to give some amount of xylocaine.
Dr. Priya, can I ask,
Yes.
why was that second incision taken? Why did you abandon the first incision? The first clear corneal incision? There was a new incision.
No, actually that was just a side port which just got a bit enlarged. It was not that the surgery was done from that incision in itself. The corneal incision was not changed. What you saw was probably, I think you are asking one of the suture that you must have seen extra on the side. Are you asking about that?
Yeah, that's okay. I saw one suture there on the temporal side.
That's what I'm saying. That was probably a side port which extra suture was taken, because when you got a vitreous, this one, you try to seal it off. Because we went through the pars plana, so you want everything to be tight into the anterior chambers. That's it.
Dr. Minu Mathan, if there
Yes.
is no nucleus drop, just a PCR, I just want a very one-line, two-line answer of yours. What would be the plus and minus of doing a pars plana or a limbal anterior vitrectomy?
If you are not confident with your pars plana incisions, and when the eye is soft and you don't have too much of cortex or epinucleus or nucleus inside AVF, I am not very confident with doing that. So I would go through the anterior segment to the limbus itself and finish off if it is a small one. But ideally, as we know, it is good to go posteriorly. It will not create more vitreous loss. It will contain the rent. That's all fine. But it has to be in confident hands.
Thank you, Dr.